Hello, welcome to UCARE LevelUp Webinar series. I'm Dr. Emek Göncü from Turkey and also from Germany now. And I'm very happy to be with you today. And we are having many registrations from all around the world, from 50 countries. I'm so happy that you are here. Thanks for coming and thanks for listening. And I'm also excited today that 1st of October is the Urticaria Day, and I'm wearing this t-shirt today to increase the awareness on urticaria disease. And so today we have a very important topic that we are always being asked by the patients, also by the physicians. All the patients ask us, do I have an allergy? Should I have an allergy testing? Should I limit my foods? So today we are going to have great answers to these questions from experts in the field. So we have today Désirée Larenas-Linneman. She is going to speak about when to suspect allergy in acute urticaria patients. And we also have Jonathan Bernstein to talk about when to suspect allergy in chronic urticaria patients, and Ana Gimenéz-Arnau on immediate contact reactions and contact urticaria syndrome. So I would like to tell you also that we will take the questions in the end, but you can type your questions to the chat function and we will answer them later. So I'm very honored to present Désirée Linneman for her speech. Welcome, Désirée.
Yeah, hi, Emek. It's really a great pleasure for me to be here with you. If you give me the option, please, to share my screen, then I can start with my talk.
Yes.
I think really the UCARE group is an absolutely fascinating group. We'll again have a gathering together with all urticaria fanatics and lovers in December. So for those of you who are joining us, well, maybe at the very end we come back to this, but then let's start. Well, urticaria and allergy, yeah, sure, as an allergist, this is a very important subject, and I hope really that my presentation will be of use to you. I will quickly go to the definition, sure, of urticaria and acute urticaria. That's just one slide. Then continue with the diagnosis, how can be diagnosed, and also very important, always know the differential diagnosis from anaphylaxis, then possible causes and triggers. I think we oftentimes confuse between causes and triggers, and many times also a cause can be a trigger or a trigger can be a cause. So I hope to share some, shine some light on that, which tests can be useful, but also which tests are not useful. And then some words, the last slide, about acute urticaria and COVID-19. Now, what about the link of those two as the disease? And also what about, we just, with leadership of Emek, published on COVID-19 vaccines and a flare, yes or no, in the urticaria. So definition, yeah, we all would like to remind you that the disease of urticaria have two different manifestations. One is the wheals, as you can see on the left-hand side, which can be just very tiny ones or can be big ones confluently, as you can see here on the picture. And it can also have angioedema. Some patients have both, some patients have only one or only the angioedema. And when it is lasting for less than 6 weeks, it's still called acute urticaria. Sure, all acute urticaria finally ends up being chronic urticaria if really the disease and the triggers continue. So this is acute urticaria that we're speaking about today. Well, how can we diagnose? Those are wheals that are evanescent. Each individual wheal does not have to last for more than 24 hours. I think that is very important because I still get patients with atopic dermatitis being treated as if it was urticaria and vice versa. Now, putting corticosteroids, topical corticosteroids on the wheals. No, these are really two very different diseases. The angioedema might last a little bit longer. It can even last 2 to 3 days max. Very important here is that there are only symptoms in the skin. We don't have to have any symptoms in other organs, because if we have them, then we are not seeing urticaria. Then we really have to think it could be anaphylaxis. And yeah, we know this is really a life-threatening disease. So it's very important always, if you see a patient with all of a sudden a lot of heaves or angioedema, to check the heart, to check for hypotension, to check for even collapse, to check the brain, if the patient is anxious, if there's a sense of pending doom, or the patient is almost fainting, if there's wheezing over the lungs, dyspnea, those are not symptoms of urticaria. Or if there are symptoms in the GI tract, cramps, diarrhea, just to mention some of the signs that could be present and the symptoms could be present when we have to think of anaphylaxis. And when it's anaphylaxis, surely the treatment is adrenaline. No, epinephrine, adrenalina, here we say in Spanish. So please be very keen on that differential diagnosis. Well, what are then the possible causes? Well, I put this very busy slide. It is a mast cell, and it are only some of the receptors that are on the surface of a mast cell. So I only would like to express with this, and this is in a very a publication I just submitted. So hopefully in 1 or 2 months you can read a little bit more about it. But there's many triggers that can trigger a mast cell to become activated and to release histamine. So that's also where we can understand there is often not even one cause for the urticaria. It's many times that there are 2 or 3 things that come together and finally release the symptoms and signs of the urticaria. So causes, well, yeah, of course, surely we understand when it is eliminated, then the urticaria shall be gone. But it's much more often to find triggers. And a trigger is something that when we avoid it, the urticaria shall become less severe. It might not flare so often, but there still is urticaria. So very much I'd like to stress here on the diet part. Now, oftentimes people think that the cause of their urticaria are several foods, and they are not eating this anymore, not that anymore, or even to the kids, they don't give them any more milk or egg or many multi-diets, and then urticaria gets a little bit less, but it's still there. So then it's really not the cause, and we should not be giving the super multi-diets. I'll come back to this a little bit later. Yeah, then to confuse you even more, some triggers really also can be causes, or some causes can also be one of the triggers giving urticaria. So, well, if we now look for what could be the causes or triggers in adults for acute urticaria, and also, yeah, several of them are for the chronic urticaria, as I already told you. If the acute one continues, then finally it ends up being a chronic urticaria. Well, the number one for the adults is medication. So always, and you don't know how many times I, again and again, at least 3, ask the patient, and you really didn't take any medication. You really didn't take any syrup. You really didn't take any pills. You really didn't. And I ask it different ways, because it's very often that the 3rd time I ask, say, oh yeah, well, now you say, yes, I did. And then they come with the medication that probably has been the cause of their urticaria. So I just mentioned some of them here. There's still a much longer list. Then the second cause in adults, when it's acute urticaria, we always have to ask for infections. Now, and occult infections. I always have for myself like a top-down a routine to not jump any possible cause. So sinus, you have a blocked nose, you have a purulent mucus. Then we go for the tooth. Now maybe you can have an infection of one of your teeth. Then we go to the stomach for the Helicobacter, hepatitis, parasites. Then we go a little bit lower, the urinary tract, and in the female, surely vaginitis. Then we go lower, and even fungus between the feet, that sometimes give an EDA reaction and can give also urticaria. Then food, but food, first thinking about foods that are more like triggers that make that more histamine is released, or that are themselves kind of histamine. So fermented foods, canned fish, aged cheese and meat, not just a very very young cheese normally is not the problem, but when it's really aged, then it becomes much more histaminergic. Chocolate, surely red wine, much more than white wine or other kind of alcohol, although also other kind of alcohol can be the cause. Then vitamins, yeah, and here the vitamins plus. Multivitamins has been causes in some of my patients, more maybe because of their in colored capsules. So sometimes the capsules, so sometimes the color is given to urticaria, but very important lately, and I always tell them I love the proteins for the gym, because the multi-proteins people take really enormous quantities sometimes to build up a better body. They're so allergenic, and it is really has been already several patients that just because of the proteins for the gym, they get their urticarias. Then you have the other one, but as you see, I put it much more on the end of the list, food that really cause an IgE-mediated reactions. Then in the adult, it can be shrimps or the things related to shrimps, nuts, peanuts, wheat, milk, egg, soy. Yeah, there can be a food allergy, but we now come how you can think that it really could be a food allergy. And then there's the stress part. I always leave it at the end because it is very, very often, this is a cofactor. And I didn't stress the point that on the mast cell, several of the receptors can react to stressful mediators that are liberated when there's stress, and specifically emotional stress. Very important. Take your time to really ask well about it. Well, for the kids, it's very similar, but for the kids, the first number one is infections, and very specifically viral infections, viral respiratory infections, viral GI infections. Then also on the other parts, they are very similar, also, only that here the most frequent foods are milk, egg, peanut. It's a little bit different, the order there. So yeah, again, stressing here, food as a cause. Please caution. When can we think that really the food might be the cause? Well, the symptoms always have to appear when exposed. It's not that sometimes when I eat an apple, I get it, and the other times when I eat an apple, I don't get it. No, then it's not the apple. Then the time lapse. I've been seeing patients here that say, yeah, I think it was a cheese that had like a bad taste. I ate 3 days back. No, the time lapse is way too long. An IgE-mediated reaction is an immediate reaction, normally within minutes. Sometimes it can be up to 3, 4, some people say even 8 hours, but definitely not more than that. And if we doubt it could be the cause, we really have to go to the diagnosis. We can't stay with assuming that it could be and then telling the patient to avoid. No, we really have to demonstrate the presence of specific IgE to the food or to a protein. This can be also molecular allergy. Now, molecular allergy diagnosis, I come back to this a little bit later. And then we have to do the challenge test to really give the food in our consulting room and see if hives come up. Very often, food is caused as labeled as a cause, as I already told you, and then really be careful, because unnecessary diets, when we for a long time, months, sometimes even years, avoid certain food, finally, the kid will end up being allergic to that food. So it's not innocuous. Now, it is a heavy burden on the family, but also we can finally be causing allergy. There's one exception to this rule. That's when you eat the food, always it has to give symptoms. Well, be careful. It has to be the same way of the food, because there can be difference between a cooked food or a raw food. And I'd like to explain a little bit more about that on the next slides. So there are sequential epitopes that are all amino acids that are sequentially on the protein, like casein. Those are very thermostable, because when the whole milk protein is broken into pieces by heating, the casein normally will stay as it's a sequential epitope. That as opposed to conformational epitopes that are only there when the molecule is exactly in the same form. So if we heated up the milk, it breaks open, and this this allergenic molecule is lost. They are thermolabile. So there can be patients who have allergy to milk and they're allergic to casein. They will be allergic and have symptoms even with heated milk, cooked milk, or whatever. But those who have only allergy to the beta-lactoglobulin, they will have no problems with cooked or baked milk. And so we can see with the different foods here, I won't go into detail. This is a very nice publication from some years back from Ana Gimenéz-Arnau, but in beef, there are 6 different proteins that can be very thermostable, so they will give allergy when you're allergic to that protein. Casein, we also said. In egg, there's some thermostable ones, also in fish, in wheat, but there's also a very interesting thing with the shellfish, that only when it is boiled, there is a neoepitope formed. So some people are only allergic to boiled shrimps and not to raw shrimps, because there is a neoepitope formed. Then there's green ones that when the thing is boiled or cooked, here in beef, in cow milk, in egg, and in fish, or when it's canned, then the epitopes are lost and you can eat that. So for the diagnosis, we really have to show the presence of specific IgE. This can be specific IgE to the whole. No, the whole, for example, here, peanut, we can do in skin prick testing or a serum test, but it can also be like molecular allergy. And here I just put one of the very nice pictures of our molecular allergy guideline here on the bottom. You can have it's in Spanish, sorry, but you can do the Google translation. But there we really explain you which molecules are linked, for example, in peanut and also in the other foods with really severe allergic reactions. So if you are allergic to peanut, but it's to ARA-H1, 2, 6, or 3, be careful, because normally those patients really can have even anaphylaxis. If it's only like an ARA-H9 or 8, it's more cross-reactivity and probably is only just wheels, so you can do the food challenge without major problems. So sometimes molecular allergy can help us to really sort out, 1, how severe the reaction can be, and 2, if there's cross-reactivity. Because as you can see here, PR10 is present in many different vegetables, fruits, also trees, and here we have the peanut. So it can be have some reactivity to several. Now, and here again, I won't go into the detail because of the time, but here you can see that if you're allergic to peanut, you can also react to many of those other fruits that are here. And we have the syndromes. Now, the apple birch syndrome, the birch hazelnut syndrome, and here you can see the soy nut fruits, because soy crosses quite a lot with the nuts, with also here the peanut. So when you really think a food is the cause, do the confirmation of food challenge. Only surely if there's not a total IgE to this peanut with very high levels, because then it's really dangerous. Sorry, I can't speak at this moment. Okay, so really do the challenge test to not end up with only the doubt that this could be a food allergy, but really confirm. Then about the COVID, well, it can be caused by COVID itself. Now, the hives, it's not so often in children, it was a bit more often in adults. And then, yeah, if you have hives and fever, we'll consider just to do a COVID test to not miss this possible case. And then the last slide of mine is this one. It's about the very recent publication just came out in JK under Emek's prime authorship. And it showed us that more or less COVID vaccination in patients who have chronic spontaneous urticaria, more or less 10% has a little bit of a flare of the urticaria within 2 days. They might last days, it might last 1 or 2 weeks, a little bit more frequent when it's a patient who has intolerance to NSAIDs, but normally it is not a major thing, and you just have to step up a little bit the treatment, and then the patient gets over this little flare that can be caused by vaccination. So please don't withhold COVID vaccination. Now the new one again now recommended by the World Health Organization, because it is important. We will have again probably at the end of this year a flare in COVID. So thank you very much. That was my part. I'll be here to take some further questions and leave the stage now to the other colleagues.
Dear Desi, thank you very much for your wonderful presentation. I'm sure you have questions, and these are very great topics, really, and thanks for referring our UCARE project. Thanks. Now, I think that Jonathan is here, and yes. Welcome, Jonathan. I hope you're fine, and we are so happy to have you. So your topic will be when to suspect allergy in chronic urticaria patients. Now the stage is yours. Thanks.
Okay, thanks. So I was asked to talk about when to suspect allergy in chronic urticaria patients, and of course, we see these patients who come in with welts all over their body, as was discussed, and should we just be focused on their hives, or should we be thinking about other, the total patient and the concomitant symptoms that they may be experiencing? Is there a relationship? And that still hadn't been entirely clear. These are some conflicts of interest. In contrast to the previous talk, which was discussing acute, this, we're talking more about chronic, and this is when wheals and or angioedema last greater than 6 weeks. And so this tends to be a more persistent hives. And when we diagnose it according to the guidelines, we certainly have to have a differential diagnosis. What other things could be this related to? We want to exclude acute urticaria, was discussed, and then once we establish it's been going on longer than 6 weeks, and these lesions are evanescent, they're coming and going, and it appears to be chronic urticaria, we certainly want to exclude inducible forms of hives. And in other words, can we make the hives and the angioedema come on through stimulation, either with pressure, or physical scratching like dermatographia, or cold, like an ice cube challenge, or just exercise, things of that nature. And it's important that we define those subtypes of hives, because many times patients can have, with chronic spontaneous urticaria, can have inducible hives, but sometimes they just have inducible without the chronic spontaneous urticaria. But once we establish that they have the chronic spontaneous urticaria, that we need to check for other systemic diseases. And we talk about disease activity, quality of life impairment, and disease control when we think about this condition. But what about other systemic inflammatory diseases, and what is the appropriate thing to do? Well, I'm just going to share with you 3 studies that I think address this association. This is a small study from Poland, which they looked at a questionnaire survey of 20 questions, and they looked at the percentage of patients with chronic spontaneous urticaria without angioedema, and they found that 53% of these patients had chronic spontaneous urticaria, but 25% actually had autoimmune characteristics. They had other autoimmune conditions associated with it, either by blood testing and or clinical conditions. And then they also had, a number of them had inducible hives, as we see. So just from this small survey, we see that patients do have a stronger association with autoimmune disease, which we know occurs in up to 50% of patients with chronic spontaneous urticaria. When they actually look at the concomitant hives with angioedema, these numbers get more pronounced. It's a smaller total number of patients, but you start seeing other, higher percentage of patients with autoimmune conditions and chronic and inducible forms of hives. So again, this speaks to the severity of the disease, and also perhaps that the maybe a difference in the pathogenesis of these conditions as well. So these are the areas that we're trying to understand better in terms of characterizing patients phenotypically to elucidate underlying pathomechanisms. Now, this was a very small study, but when they looked at other conditions, atopy and allergies, chronic inflammatory and infectious diseases, thyroid disorders, they found a significant percentage of patients, almost 50% of patients in this small cohort had atopy and allergies, and and then a third had chronic inflammation and infection. And then as well as thyroid disorders. And we see also that other conditions like psychiatric diseases, other skin disorders other than allergies, other than hives, gastrointestinal disorders, connective tissue disease. All these other things occurred in these patients. Now, of course, patients with hives are normal patients, and these diseases occur in normal individuals as well. So is there a higher association compared to patients who present without urticaria? And again, just to add to this information, that not only did they have, these conditions, but there were actual combinations of diseases, more than one that was diagnosed in this small population. The numbers are, again, small overall, but it tells you that this is a prevalent association. And other studies have demonstrated a strong association between autoimmune diseases and urticaria. Now, the next study, though, is a larger study. This is actually from Israel, which was characterizing using the conscripts from the Israel Defense Forces. They have large numbers of people and they collect a lot of information. So it's very useful in identifying, characteristics of chronic disease. In this case, they asked the question, what is the association of other conditions in adolescents? These are young individuals who have chronic urticaria. And so you see that the control population was over 1 million, and there were 6,600 patients with chronic urticaria. So, of course, we know that females are more prone to hives than males. And what was interesting is that the higher socioeconomic index score was more associated with urticaria, and a higher level of education was associated with a higher incidence of hives. And they compared it to different places of birth, whether it was Eastern Europe, Ethiopia, or Israel. And again, the percentages were higher in those who actually were born in Israel versus other regions of the country. Now, this is interesting because this speaks to the concept of evolving microbiomes that could be playing a role in the development of atopy. And if we think of hives also as a condition that is influenced by type 2 inflammation, this could be a hint that perhaps changes in diet, Western diet, from a different type of diet could influence progression of these associated conditions. They found that the comorbidities in using univariate analysis, there were a lot of the same conditions I mentioned before, asthma, allergic rhinitis, food allergy, were all significantly greater in patients with chronic urticaria, and actually were even more pronounced in patients with severe chronic urticaria. So the more severe the disease, the more also highly associated were these comorbidities, both autoimmune disease and atopic disorders, as well as some other conditions like celiac psychosis, depression, anxiety. But when they did, they focused on the prevalence of atopic diseases and just the severe chronic urticaria compared to the control populations, they found that, again, a strong association compared to the control population in these allergic disorders: food allergy, allergic rhinitis, asthma, atopic dermatitis, and chronic sinusitis. Now, of course, looking at multivariate analysis, these associations, comparing between chronic urticaria and severe chronic urticaria, they were all quite significant for these atopic disorders, as well as these autoimmune conditions. And so I think this sheds light that there is and these are large populations, so there is a strong association, not just to autoimmune disease, but also to atopic disorders, suggesting that hives are a type 2, Th2 type inflammatory condition. But there are different phenotypes, perhaps. And of course, what influences the evolution of type 2 inflammation is, obviously why it could explain why there are these high associations. So their summary of their data was that chronic spontaneous urticaria is usually regarded as an idiopathic entity, occasionally associated with autoimmune phenomenon, but they need to look at it. They need to do more work to understand the relationship that it has to atopy. But understanding this association might provide pathogenic insights and improve patient management. Now, the last study I'm going to show is a study from Turkey, and Emek is directly familiar with this study. And this was looking at differences between adults and pediatric chronic spontaneous urticaria from a cohort of 751 patients. And this is, they looked at clinical features associated with associated conditions and indicators of treatment response. And they wanted to determine differences between pediatric and adult chronic spontaneous urticaria in terms of clinical characteristics, laboratory parameters, comorbidities, response to treatment, indicators of response. So this is the demographics, and they broke it down into less than 12 and greater than 12, but they also had other analyses that were looking at even younger ages, but basically showing that, that again, females are much more prone to this condition, and of course, angioedema was more common in older children than in the younger children, and again, atopy was more common in the older population than the younger population. We look at the specific characteristics, differences between the pediatric and adolescent adult population, less than 12 and greater than 12. You see that, again, illustrated females more so than males, angioedema more common in older people, but atopy more common. And then all of these other markers that we've used to look at autoimmune or autoallergy, and also maybe that might be useful for as prognosticators for treatment response, seem to be more prevalent in the older population compared to the younger population. And when we look at the laboratory characteristics and certainly the conditions in the children versus the older individuals, again, you see that these markers are much more pronounced in the older adult population, 18 years of age and older, and it might be more useful in that population to predict response to treatment. And when they looked at that, actually, they looked at patients with response to treatment versus no response to treatment. They found that obviously angioedema was a marker of poor response to treatment, but also disease duration, but skin prick positivity to aero allergens was also a significant predictor, as was eosinopenia, but not some of the other traditional. Of course, elevated CRP was a good marker for poor response to antihistamines as well. So again, using this data analysis, this was again a retrospective data set analysis. They're able to tease out some characteristic differences between these subpopulations and found that atopy again is a comorbid illness as well as autoimmune conditions that influence the disease and its response to treatment. So when we look at the summary of chronic urticaria management from the guidelines, we start by assessing and looking at diagnoses to exclude mimics of hives, but it emphasizes the importance of looking at comorbidities, especially in special populations, children and pregnancy. And so we really don't want to ignore other diseases. They may be coming in with hives, but they may also have allergic rhinitis and asthma, or they may have joint pain or other rashes and or other clinical characteristics that might make you suspect other comorbid conditions. And these should be assessed because they do seem to be much more prevalent in patients with urticaria. And then again, looking at all of these conditions are part of the initial assessment. And again, the ACT obviously start treatment, but hopefully as we move forward into understanding biomarkers and how they predict disease, these might be more important to incorporate in the initial evaluation, in addition to using patient-reported outcome measures to assess control, and that will influence whether treatment is stepped up or stepped down based on levels of control. Now, so this is the old study that shows should diagnostic testing be performed, and in this particular analysis, where they just looked at testing that was done in all patients presented with urticaria, they found that it had very little utility in influencing management. However, with the data that we're now accumulating, and this is just a nice example of the most recent updated international guidelines. Can we use biomarkers to predict response, poor response, or good response to the medicines that we use in these guidelines, high-dose antihistamines omalizumab, cyclosporin. And of course, there's evidence to support that they may be useful, but this is still not, these markers are still not validated or definitively proven to be useful in this context. But I think as data emerges, we might have stronger evidence to support that. But certainly it suggests and indicates that all of the hives that we treat are not the same. It's not one size fits all, that there are different phenotypes and there are different subtypes, and these comorbid illnesses could be influencing the natural course of these diseases. So with that, I'm going to conclude. I'd like to thank you for your attention, and hopefully this has given you some additional perspective when you look at a patient with chronic spontaneous urticaria, that we need to go beyond the skin and understand the comorbid illnesses that these patients are experiencing, because they may be directly related to the underlying pathomechanisms of chronic urticaria. More work is needed. Thank you very much.
Thank you, Jonathan, for this comprehensive presentation. Next speaker is Ana Gimenéz-Arnau from Spain, and she's going to speak about immediate contact reactions and the contact urticaria syndrome. The stage is yours, Ana. Welcome. Yes.
Then, nice evening. It's good for me to be with you, Emek, with Desi, with Jonathan, and with the entire team of the LevelUp Webinar team, and also with the colleagues that are in the other side in this virtual meeting. I will focus my attention in a thing which is completely different. That means is immediate contact reactions. And then I will focus, or I recommend you to read these two books that are shared by Howard Maybach. And in 15 minutes, I will review such concept, immediate contact reactions. That means that such immediate contact reactions can be WILS, that means contact urticaria. You can hear a non-immunological contact urticaria induced by urticaria bonica. On the right, you have a protein contact dermatitis induced immediately after protein contact, reproduced by prick testing. Then we will focus on three concepts: contact urticaria, protein contact dermatitis, and the contact urticaria symptoms that can be expressed in WILS and also on eczema. The concept of contact urticaria was created in 1973 by Alexander Fischer. Obviously, we know that urticaria lesions can be induced by hairy caterpillar, and also those property, the urticariogens property, were used therapeutically in the old times. In the 1976, Niels Hjorth and Rod Peterson in Denmark created the concept of protein contact dermatitis because some people suffer, especially people handling foods, of immediate WILS and eczema, and 50% of them were atopics. Then they expressed eczema by the immediate contact of protein, but simultaneously, Howard Maybach and Johnson in the 1975, they reported a case of contact urticaria, and the inducer was a low molecular weight, the ethyl toluamina. Then we have three concepts that grow together, and we can join all of them in the urticaria, contact urticaria syndrome. From the epidemiological point of view, the things that are published are just cases or series of cases, and just the epidemic of contact urticaria induced by latex has good epidemiological population-based study. What we have is good occupational-based study, especially from Finland, from Kanerva, and from Aalto Korte, and from Australia. But there are some good epidemiological approach in the occupational setting, and we can consider that contact urticaria is probably, after chronic hand eczema, the most common occupational induced disease. 3% of contact urticaria in Norway by Alfonso published, induced by animal products, fish, etc. But also, for example, in Pakistan, 1% of the cases is contact urticaria in people who were studied. Then which works can induce occupational contact urticaria? Food industry workers, agriculture, hunters, veterinarians, laboratory workers and biologists, healthcare workers, pharmaceutical industry, hairdressers, plastic industries, etc. There is just one occupational questionnaire, the Nordic Occupational Skin Questionnaire, that address just one question, asking for if the patient, if the workers suffer from contact urticaria. This questionnaire is adapted and completely translated to Spanish, and is the only one who has it. How these immediate contact reactions are presented? It can be wheals, evanescence, eczema, that means permanent, with impairment of the epidermis and presence of the vesicles, but also just with itching sensation. This is how it's expressed in the skin, and it can be expressed in the same patients, all the three things, itch, eczema, and wheals. This can, for example, induced by aloe vera, or in the right you have an eczema, a hive or wheal, and an eczema with the epidermal destruction because there are some tiny vesicles, always is with itch. Can be generalized? Yes, you can suffer a generalized urticaria induced by contact of these subjects, and also you can have systemic syndromes. In this case, then you go to directly to the differential diagnosis with the oral allergic syndrome, and somehow, for example, with latex, we can even suffer from anaphylaxia. When we focus, when this is interesting in this approach from the Finnish colleagues, is that these from 291 cases of occupational contact urticaria protein contact dermatitis, such patients also, at least 21% of them suffered asthma, and at least 38% of them suffered rhinitis. And the inducer of such systemic involvement were the same agents, the same triggers: flow, cudender, natural rubber latex, or other things. Then the first thing is that in the contact urticaria syndrome, the same patient can suffer wheals, eczema, itching, induced by the same trigger that can be a protein, but also a low molecular weight. The mechanism can be non-immunological and immunological for contact urticaria, non-immunological induced by sorbic acid, for example, because the trigger just acts through the nerves or through the blood vessels. This is the case from the needles, the stinging needles that include histamine and serotonin and acetylcholine inside of the needles. Or it can be immunological, and this is the typical one, is latex, where we already identify many antigens, or is this little animal, which is responsible of 100% of itch, 52% of wheals and flare, or even persistent papules or dermatitis, where at least 3 different allergens has been described. This is immunological, and first was non-immunological. What happened with protein contact dermatitis, whose pathological or who pathogenesis is not known? We can imagine that in the protein contact dermatitis, something is similar about the atopic induced eczema by a protein, for example, dust mite. That means we have eczema, and probably we have an IgE-related reaction against a protein who crossed the barrier function, and obviously, probably, the immunological pattern will be a Th2. Then the second learning that we have is that protein can induce urticaria, chronic urticaria syndrome, or urticaria syndrome, contact urticaria syndrome, and also low molecular weight. And how we study them? Because traditionally, we use a protocol from non-invasive to invasive to more invasive. That means we can use patch testing, open patch testing in healthy skin or in affected skin, the foot, for example. Or you can use it by patch testing occlusively in healthy skin or in affected skin. This protocol is very long. It's just to try to demonstrate that the contact can induce the reaction. But the most easy thing is to do a prick-by-prick test. And they directly do a prick-by-prick test, a technique which is not standardized, but is very useful. And here you can have, for example, the wheals induced with a prick-by-prick test with those fruits in a lady who was a fruit seller, or this protein contact dermatitis that started with wheals induced by the prick-by-prick test by their own fishes that the lady was handling, she was touching, not by ingesting, just touching. Then we are long list of agents that can induce this contact urticaria syndrome in one form or the other. And we can classify them by molecular weight, mechanism of action, immunological or non-immunological, occupational relevance, or our common use in our daily lives. This was our first approach, in this case with Howard Maybach and Marcus Marr a long time ago. And even when we read and publish and became with more literature, we are doing long lists and increasing the list of triggers in this type of disease. Then animals, plants, and derivatives can cause it. Foods and food additives can cause it. Enzymes responsible for immediate contact reactions are responsible. Fragrances, cosmetics, preservatives, drugs, even metals. And there is one chapter where Cristina Altocorte explained how to prepare the metals to put and do a pre-testing. And even a miscellaneous list, a long list of substances. Here you can have the example of protein contact dermatitis induced by a viscera, reproduced by prick-by-prick test, by courtesy by Jesus de la Cuadra from Valencia, now retired, or this cuttlefish induced this eczema, protein contact dermatitis, reproduced by prick-by-prick in these ladies that really were protected with gloves, but in this area that was not protected, they suffered the dermatitis. Or this, even also this protein contact dermatitis induced by eating on contact mango in the lips. And we have long list, and this long list will be increased. But recently, what we had is some approach of what happened during the COVID pandemic, and there was something published on contact urticaria due to the surgical mask or hand sensitizer. But for me, which is much more interesting and will be probably published in the future, is the reaction by contact with the cannabinoids, with cannabis. They are already published in an occupational setting. And also then we can, how we should treat these patients, because we have this non-immunological contact urticaria, this contact urticaria, which is pure wills, and this protein contact dermatitis. Initially, maybe different diseases. If you asked me about my experience using salicylic acid or non-steroidal anti-inflammatory drugs for non-immunological contact urticaria, I will say I don't have any experience. This is commonly is a question. I have a lot of experience managing contact urticaria, as previously Bernstein showed that in the group of inducible urticaria where angioedema was not present, contact urticaria showed a prevalence of 4.9%. When the inducible urticaria increased and presented angioedema, the fourth was contact urticaria. Then it's considered an inducible urticaria, which is not physical, and how it was treated according with the protocol that we use in our chronic urticaria. Then first, anti-H1. And how we treat our protein contact dermatitis as an eczema, normally with topical corticosteroids or topical calcineurin inhibitors. Obviously, if it fails, you can use other things. You can use phototherapy, etc. But recently, even has been published the possibility to manage refractory contact urticaria, which is immunologic, using an anti-IgE therapy, okay, omalizumab, or using for protein contact dermatitis, which is refractory, then dupilumab. And we'll see what happens, because as you know, Emek, as you know, my colleagues, dupilumab is also will be labeled for chronic urticaria, chronic spontaneous urticaria. Then we have other possibilities to treat our patients. Just to conclude, they asked me some ideas to go at home with just key message. The first message is that we should recognize the patients that suffer this type of disease and report it. We should really increase our population-based study, which will be difficult. We need to assess the occupational relevance, take care of this because it's important. We need more insight in the systemic pathogenesis and try to be open and not say eczema and urticaria, type 1, type 4. There is a mixture. There are people who suffer eczema mediated by IgE and driving by a Th2 immunological pattern, protein contact dermatitis, and probably and sometimes the same trigger can express clinically in both forms. This is what I wanted to show to you. And from the very beginning, from this very first paper that was really worked by me in deep, the concept of immediate contact skin reactions should be taken into account. Thank you, Emek. Thank you, you all. Thank you for being here. And see you, I hope, in person soon.
Soon in the EADV, we hope to meet in Berlin. Yeah. Thank you for this wonderful presentation, Ana. And I have a question for you. Do you think, do you agree with the classification of contact urticaria as an inducible urticaria? What's your opinion about it?
I think that is an inducible urticaria, but when you see it in the table of inducible urticaria, is something different. It's absolutely different. Then obviously it's an inducible urticaria, and it's chronic because it can be relapsing if you are exposed to the agent which is responsible. And it's not necessarily immunological. It can be non-immunological. It's inducible and it's chronic. But it really feels you a little strange, no? Position, seeing it there. That's
something different. Yeah, my feeling is like, I agree with you. Desi, do you also agree, or do you have another opinion about it?
Yeah. When we made our Mexican guidelines on urticaria, with the team, there was even somebody, and finally we accepted that proposed to differentiate physical inducible and chemical inducible. And then in the chemical inducible comes also the sweat, no? When you the cholinergic one. So yeah, there it might.
Yeah, it was like it was like this in the previous guideline. The previous guideline, there were the differentiation between physical and chemical, and after it was eliminated.
Yes. Okay. Thank you. So Ana, do you also have patients with chronic urticaria and contact urticaria together?
Commonly, no.
No, it's not common. It's not common. So
it's not common.
Maybe,
no.
Yeah. Maybe
I have patients with contact urticaria which are atopic patients. This is much more common.
Yeah, the coexistence is with atopic disorders rather than chronic urticaria. Yeah. I agree. So what are some clues that physicians can suspect contact urticaria in a chronic urticaria patient, for example?
We had different. Let's see. Maybe you can agree, Emek, you can agree with me. We had different funny experience with our patients with chronic spontaneous urticaria, because when the wheals appear by routine daily, we identify CSU. But if you go to an accurate anamnesis, probably the wheals are appearing because they are doing daily, which is something that induces. For example, we had a case that was diagnosed of chronic urticaria, and the reason was a drug, metformin. Stopping the drug, the disease disappeared. It happens also with a lady that was in a clinical trial. But she was taking metformin daily, and she was suffering daily wheals. Then, and it can happen also with, if it's contact urticaria, you're touching the things, no? You're touching the things, and you don't have a systemic disease commonly. But for drugs,
but Desi focused on it very, very perfectly, that I'm asking 3 times to the patients, have you been using medication? Yeah, you're so right, because they never remember, they don't think it's important, and they don't give us the information. You're so right.
Yeah, and I even introduced the question. So, sorry, I know I already asked you, but really, because I have had the and I come again. Yeah, what is it? Ana said, I had a very interesting case. There was a guy who finally he made urticaria highs when he took coffee from those cups, the Nespresso apparatus. And he normally, he bought this apparatus at home. He started to take the coffee like that, started to have the wheels. And as he took his coffee every day, so it was like a chronic urticaria. When did he realize it probably would be that? When he had to leave on a business trip and he was 2 weeks away, and there was no cup coffee. So he took a normal filter coffee and no more hives. And then he came back and it was again the hives. And then he went to another place where there was, because then we thought it was something of the environment here in Mexico. Yeah, a lot of allergens, a lot of irritants, etc. But when he went away on another business trip where there were cups and he still continued with the hives, that's when he was keen on thinking on, and we did finally the aluminum test and he got a big wheel there. Yeah.
This is incredible.
Very interesting.
And it's, is the patient give you the answer to your question?
The clue. He gave me the clue. And really,
because, and even when we are seeing patients with CSU and we don't have time, we should take patient and listen and start and again and again and again. Yeah. And this morning we were five in the office looking for patients with CSU, and I had the impression that sometimes I cannot nowadays do the things correctly. We should really listen to the patient many times.
Yeah. So true.
Yeah.
But Daisy, was the patient's urticaria lasting for a few hours or all day? Do you remember this detail? Because it may be an important clue.
Yeah. No, the important thing here was it was more a pressure urticaria. So it wasn't in urticaria, and he would get it when he played golf. But only when it was this combination with the coffee. So it was not a chronic spontaneous, it was a pressure.
Desi, and do you think, as Martin Church says, and Claire Grattan, that sometimes for acute urticaria, there are people with a background of chronic spontaneous urticaria, which is not manifest. Then after, if they include 2 or 3 things, triggers, they have an acute urticaria, and after they maintaining as chronic one?
Yes. I very much, this is why I love this picture of the mast cell with all the stuff around, because I absolutely think that very often it's not one cause. It's just you sum up, and then you get the problem.
And for acute urticaria, Desi, you commonly will order allergic tests?
No,
good.
No, absolutely no. No, I think there's no indication, because also then they do the testing and then some wheels come up, because just if you scratch, you get a wheel, and because they're still a little bit unstable. And then sometimes they even put an allergen immunotherapy, which I think is completely out of, no. There are the rare cases, yes, and Jonathan showed them, where there is inhalant allergen. So I do have some urticaria flares here in the winter when there's a lot of ash tree pollen. So yeah, those, but then they also have some rhinitis or some asthma added to it, and then the allergen immunotherapy gets the urticaria go away.
Good.
Yeah, really interesting. Okay, so let's go to the Daisy. You already answered some of them, I guess. But we didn't have many questions. So Sibel from Turkey asked, are there clues to differentiate between acute urticaria and anaphylaxis in the emergency department? So, and you answered her. Yeah,
I think really the case that she put up now, the patient comes in, has a lot of hives all over the body, and it's wheezing and a little bit now. Definitely for me, that is not an acute urticaria. For me, definitely that is an anaphylaxis. It should be treated as an anaphylaxis. I reflected a little bit when Jonathan presented that when I said, no, there should be no other organs involved, because if they are, it's not urticaria. Sure, this for the acute one. No, but then the long one, I completely agree that there's quite some patients with urticaria, chronic spontaneous urticaria, added to asthma or other T2 diseases. Yes. Or autoimmune diseases when it's more autoimmune urticaria. So yeah, yes. There's really differentiation between the acute situation and the more chronic one, where you can have absolutely, yes, other T2 organs involved.
Desi, yes. Question, and I make a question. Did you have experience of acute induced urticaria by omalizumab? or acute exacerbation urticaria induced by omalizumab? You never had this experience?
Yeah, I had such patients, especially at the beginning of omalizumab treatment. For the 2-3 injections, some patients had exacerbation of their urticaria. But I didn't have any acute inducible urticaria. It's interesting. Did you have such patients?
No, I asked you because we have 2 cases now that we should deal with them, because we have experience of acute urticaria and exacerbation of urticaria with antihistamines, and we already studied.
I know your cases, 6 cases.
Yeah, and we have others. We believe on these, but for Oma, it's just a question for you as experts.
It was not inducible. I had one who was put on omalizumab and also very nervous and well, with omalizumab, perfect. But then there was no more economy to continue, so he stopped. And urticaria came back. So then he said, no, I do want to go back to omalizumab. And then when we restarted omalizumab, he got hives getting worse. So finally he went away. I don't know. He didn't come back here.
Okay.
Yeah.
Good.
Yes, but then these patients respond to omalizumab. After waiting for a few injections, they start to respond to omalizumab. So it's important to say the patient not to
be nervous,
stop their antihistamines. Sometimes they stop their antihistamines, and this happens. And sometimes it's maybe the receptors are being freed by omalizumab, and then the other allergens can be coming. For example, the IgGs may be stimulating the mast cells and causing these reactions. Maybe
good. It's different from the subject of today, but thank you so much.
Yeah, very interesting point.
So it seems that we don't have to call Jonathan so he can take care of his patients. I'm sorry but maybe do we have other things to answer? Desi, you have answered them all. So, and Aaron made a comment that the most important clue is the short lasting urticaria if we have to suspect from allergic responses in chronic urticaria patients. Yeah, the wheals are episodic, they are short-lived, so there are some clues. For example, we had a patient with latex allergy and chronic urticaria, but the latex allergy symptoms were very obvious. You know, she was having sneezing and allergic conjunctivitis, swollen face. So
it happens. It can happen.
Yeah, but they can also coexist. So I'd like to thank all of you in the survey. We are also thankful to our sponsors, Novartis, Allakos, and Mosby, as I remembered. And thank you for your attention and interest in our webinar. Bye-bye.
Thank you. Bye, Ana. Bye, Emek. Bye, Jenny.